Hello, good evening everybody and welcome to PressureWise. My name is Dr. Rachel Climie and I'm the Public Engagement Lead on the High Blood Pressure Research Council of Australia and a Research Fellow at the Baker Institute in Melbourne.
And I'm Dr. Dean Piccone, Chair of the Early Career Research Committee of the High Blood Pressure Research Council of Australia. I'm a Research Fellow at the Menzies Institute for Medical Research in Hobart.
Hey, before we go any further, I would just like to acknowledge the traditional owners on from the many lands on which we meet tonight and pay my respects to elders past, present and emerging. So PressureWise is an initiative of the High Blood Pressure Research Council of Australia and the Heart Foundation to provide you, the Australian public, with up-to-date information on the risks and management of high blood pressure. This is because high blood pressure is the leading modifiable risk factor for heart disease, which kills more Australians than any other disease. So tonight you'll be hearing from some world-renowned experts and also some emerging researchers who all work on high blood pressure.
So we'll start with 4 presentations on the risks and management of high blood pressure and heart health, followed by a panel discussion. If you have any questions for the speakers, please type them in the Q&A box at the bottom of your screen and these will be answered during the panel discussion. Finally, 6 young scientists from around Australia will give you a taste of some of the work being conducted by our emerging researchers. Unfortunately, we will not be able to assist with any technical difficulties that arise throughout the webinar. Finally, we would like to thank Natasha Whitwell, Jade Gibson-Mears and Professor Marcus Schlag from the High Blood Pressure Research Council of Australia and Natalie Raful and Bill Stavresky from the Heart Foundation for making tonight possible. So without further ado, I'd like to introduce our first speaker, who's Professor Marcus Schlag. He's President of the High Blood Pressure Research Council of Australia and a renal physician at the Royal Perth Hospital, and he's head of the Dobney Hypertension Centre. Marcus, over to you.
Thank you very much, Dean, and big welcome to everybody out there. First off, I really would like to thank Rachel and Dean for organizing this meeting. On behalf of the High Blood Pressure Research Council, we're really seeking to engage much more with the community out there to provide you with up-to-date knowledge and help management of high blood pressure in the community. And it's wonderful to see that there's a lot of interest out there. We've got close to 200 registrants. That tells us that there's certainly a need of education. So welcome to tonight and thanks again, Rachel and Dean. So my task today is to just give you a bit of an introduction. What is blood pressure actually? Why is it dangerous to have elevated blood pressure? And what can we do about it? I was given 10 minutes and I'll try to be covering all those aspects in a reasonably short period of time. So what is blood pressure? What are these 2 magical numbers you usually see when you measure your blood pressure at home? The systolic and the diastolic. In this instance, 120/80, and there's a third number, 70, which is actually the heart rate. Now, if you imagine a closed loop that is driven by a pump, in this instance, the heart, whenever the left ventricle, the red part here of the heart contracts, it pushes the blood out into the circulation. And obviously, with that push, with that wave, it creates a certain pressure. This is the so-called systolic pressure. Systole is the part of the heart cycle where the left ventricle contracts, and that equates to that 120. Now, once the ventricle relaxes, there's still blood flow, but obviously at a lower level, and it gives the heart time to receive blood from the peripheral circulation, and this is the diastolic blood pressure. Both readings are important. There is general agreement that the systolic is perhaps a bit more important in terms of the risks that come with blood pressure, but we certainly have to look at both of them. Now, the heart rate is essentially the frequency with which the heart pumps, and all of these factors, of course, can contribute to these specific numbers. Now, blood pressure or high blood pressure is quite common. Around a third of the adult population suffers from elevated blood pressure. And really the only way to find out whether your blood pressure is elevated is to measure it. Unfortunately, elevated blood pressure often, not always, but often doesn't cause any specific symptoms. You see some of the common symptoms here on the slide. Headaches, for example, sometimes an irregular heartbeat, palpitations, regular nosebleeds could be an alarm signal that there's an increase in pressure in your system, heart problems, breathlessness. But a lot of these factors are not necessarily specific to blood pressure. They can occur under other circumstances, and often people don't make the link. So the message here is it's often an asymptomatic condition, and you should know your numbers and have your blood pressure measured. Now, how is blood pressure, or high blood pressure rather, defined? And this is an extract from the Heart Foundation guidelines, and we've got a representative from the Heart Foundation speaking a bit later, which we're looking forward to. So at this stage, hypertension starts when the blood pressure is above 140 systolic or above 90 diastolic. And you have different grades of elevated blood pressure or hypertension. But you also see that an optimal blood pressure is usually considered below 120 over 80. So we should strive to achieve these optimal blood pressures, but that may vary slightly under certain circumstances. So the 140 over 90 as the threshold for the definition of elevated blood pressure is something to keep in mind, and you definitely want to be below that specific number. The next question that often arises is, well, what causes high blood pressure? And it is a multifactorial condition. And certainly, as you see on this slide, genes can play a role. We know if high blood pressure runs in families, children are more susceptible to develop elevated blood pressure in the future. Not much we can do about the genes. There's also gene-environmental interactions, and that comes with gender, ethnicity, etc. Again, not much we can do about. But the most important factor is most likely the environment, and that relates particularly to lifestyle, and we hear about that a bit later on. So what you can contribute to your own health is focus on a healthy lifestyle, and I have some more slides in that regard. And that gives you, despite your gene set, the best opportunity to stay healthy and not develop high blood pressure and its detrimental consequences down the track. Now, which factors contribute to elevated blood pressure? And this slide is divided into those we can't really do much about. On the bottom, increasing age is usually associated with higher blood pressure, ethnic background, family history, gender, and during pregnancy, we sometimes get a rise in blood pressure. But on top, perhaps more importantly, are the factors we can do and work on. And this is our weight. Keeping a healthy weight is important. Reducing your salt intake. And in Australia and many other industrialized countries, we certainly use too much salt, often in processed food. Alcohol use, we should only drink moderately to keep blood pressure at bay, and we should be physically active, and ideally, of course, not smoke, and try to prevent specific stressors where you can. I certainly know this is easier said than done, but very important, and it can be very effective if you manage that. Now, is high blood pressure dangerous? Does it matter whether my blood pressure is elevated or not? And indeed, there's no doubt about the dangers of elevated blood pressure. This is from the World Health Organization, and it gives you a bit of an idea about common causes of deaths worldwide. And I just want to focus on this one down here. There's estimations that around close to 11 million deaths every year are directly attributable to uncontrolled or high blood pressure. So it is the single biggest killer worldwide. So you can see that there's a big risk, and certainly more important even than the other risk factors, but of course we try to keep all of these at bay. Now these numbers are huge, and the Heart Foundation has done a great job in terms of getting us a better idea what that actually means. Today we are spending, let's say, around 1 or 1.5 hours, and in that 1 hour, every 12 minutes, an Australian dies from cardiovascular disease, and 6 patients within, or 6 people within the next hour will unfortunately suffer a stroke. So this is what these numbers really mean in the context of what we see globally and in Australia. And why is that the case? Well, imagine you have elevated blood pressure in a vascular system, and that pressure will put strain on all the organs that are fed from this system. And this is in particular the case for the brain and cause the strokes. It can cause blindness by affecting the vasculature in the eye. It can, of course, cause heart attacks in the heart failure, and also, very importantly, kidney failure. So these are all things we're really trying to avoid. And again, with lowering blood pressure and taking care of other risk factors, people may have diabetes, high cholesterol, you give yourself the best chance to avoid these detrimental consequences. And can we do something about it? Absolutely. I mentioned it already, and I glanced over this very quickly. All those lifestyle modifications can have a significant impact on blood pressure. So we encourage every patient with high blood pressure to try to adhere to those, because they may really make a difference. And if that is not sufficient, we have extremely good medications, blood pressure lowering medications, and you see a number of them here. We're not going to go through in detail, but the most important aspect is if your doctor provides you with a script for blood pressure medication, you need to take them. Drugs obviously don't work if they're not being taken, and we prescribe them for a good reason, and they usually work. They can have side effects, but if that occurs, please discuss with your general practitioner. But taking your medication is crucial, and that usually works very well in terms of lowering blood pressure. Now, the final minute I would like to spend on COVID-19, which of course is in all our minds, and Australia has done reasonably well compared to the rest of the world. On the 26th of November, the status was that we had just below 28,000 cases, unfortunately slightly more than 900 deaths, and we've gone through a second wave. But while this is predominantly a lung disease, a respiratory disease, we do know that cardiovascular diseases and conditions such as hypertension may make you more susceptible to have COVID-19. And these are data from the US showing that high blood pressure, for example, is one of those conditions which is often associated with patients who have attracted COVID-19, and others are listed here. And there has been some media coverage about some blood pressure lowering medications possibly increasing the susceptibility to be infected with COVID-19. 2 specific drug classes, ACE inhibitors and angiotensin receptor blockers, very widely used. And the theory was that these drugs may increase the expression of these ACE2 receptors, which are the docking station for the virus. So if that were upregulated, there is theoretically the chance that you may attract the virus. But very recent studies have shown this is not the case. There is no association between those medications and the severity of the drug. So the message truly is stay on your drugs, which are prescribed for a good reason. And that brings me to my take-home messages. High blood pressure is very common. 1/3 of adults suffer from it. Often it doesn't cause specific symptoms. So you need to know your numbers. Maintain a healthy lifestyle. If medication is required, please take it. If you have issues, discuss with your GP. And in the era of COVID-19, please stay on your blood pressure lowering medications. But if you have concerns, talk to your GP. So I'll leave it there, and I'm looking forward to the next presentation, which will be about blood pressure measurement. This is what I did when I was a young student until I learned this is not how I should measure blood pressure. So we certainly will hear how to do it better. Thank you very much for your attention, and enjoy PressureWise.
Thank you very much, Marcus, for a fantastic presentation. So we'll move directly to our next presenter, which is Professor Olta Skutta, and she's lead of cardiac, vascular and metabolic medicine at the University of New South Wales and the George Institute for Global Health. She's also the immediate past president of the International Society of Hypertension. So over to you, Olta.
Great, thank you very much, Dean, and also to the organisers for inviting me to present today. I'm delighted to speak about this topic because I think measuring blood pressure correctly at home is extremely important, and also to take medication. I think Marcus nicely alluded to that already. So firstly, we are all very well familiar with taking clinic blood pressures. This is a traditional way of taking blood pressure measurements at the doctor or at the hospital. But there's more and more emphasis now in the medical community on the importance of taking blood pressure out of office or home blood pressure measurements. And that is quite different from the blood pressures taken in the clinic. So Marcus has now nicely demonstrated the different types of blood pressure, systolic and diastolic blood pressure. And on this graph, you can clearly see individuals' blood pressure during the course of a day, from 6 o'clock at night till 6 o'clock the next night. And here you can clearly see how blood pressure drops during sleep and how it increases significantly when we wake up with the normal fluctuations during the course of the day. That is quite normal. So the important message here is that blood pressure is variable, and it's from second to second, it really changes. In this case, you can see that this patient went to the doctor and blood pressure was measured, and this is characterized by a significant spike. This is not abnormal. This is quite the effect that we see due to anxiety, and it often happens, which makes it quite difficult to actually diagnose blood pressures based on hypertension based on blood pressures taken in the clinic. If blood pressure were to be taken at home in this case, the patient would have been more relaxed and blood pressure is a lot lower. In this case, about 10 o'clock at night or about 10 a.m. in the morning. And it's clearly reflected here that the clinic blood pressure would be very high, 166 over 101, compared to 10 o'clock at night, which would be in the normal ranges. So Marcus clearly indicated that 140 over 90 for clinic blood pressure is typically regarded as having hypertension. So in this case, the individual has normal blood pressures, but due to that white coat effect in the doctor's office, it is quite high. So why take it at home? Firstly, I've demonstrated less anxiety, so that we avoid the white coat effect. It's not only taken once. So when you have a machine at home, it's easy to take it on a daily basis in the morning and at night. And so you can get a true reflection on actual resting blood pressures. In addition is when a patient records their own blood pressure, there's a closer involvement of the patient to become more engaged with their own health and to check how well blood pressure is controlled. Is it lower than the target of, for example, 130 over 80, which is what we ideally want for home blood pressures, or is it high, suggesting hypertension? And that would also encourage patients to take their medication. Marcus also alluded to that, so it's extremely important that when medication is prescribed, that it's taken. So I'll get back to that a bit later. The Heart Foundation has produced a beautiful leaflet, easy to follow, with several easy steps to follow to take home blood pressure measurements. It's really not difficult, but there are some very important aspects to be aware of. So as you can see in this image, the person is sitting comfortably on a chair, feet apart, arms rested and back supported, using an electronic blood pressure device. So the first bubble indicates a very important aspect, and that is to take blood pressure using a validated or accurate blood pressure monitor. Not all monitors that you buy in Australia are validated. In fact, most are not. So it's usually the ones that are more expensive that are the validated ones, and there are ways to check that. So I just want to leave it there. It's also not advised to use machines that take blood pressure on the wrist or at a finger. The cuff, how the cuff is fitted around the arm is quite important. It should fit properly. If it's too tight or too loose, blood pressure measurements may be inaccurate. It's also important that the arm is supported at heart level, or that the cuff is supported at heart level. Another aspect is important, and that is the 30 minutes before you take your blood pressure. You shouldn't eat anything. You shouldn't drink your medication. You can drink it right after the measurement. You shouldn't smoke or exercise. It's really important to be in a calm and restful position. In addition, if you are stressed or they experience any pain or anything, it may cause anxiety, which will again increase your blood pressure. So rather wait until you are calm and in a rested position and state this before taking your measurement. An important thing is also to wait for 5 minutes before taking it. So you connect the cuff and then just sit and relax for 5 minutes before taking the reading. Sit with the feet flat on the floor, not crossed. The legs shouldn't be crossed. That increases the blood pressure. And also make sure, as I said before, the back is supported and the arm is supported. Importantly for home blood pressure monitoring, it's important to take it not only once, but on a regular basis. There are several benefits, as I've mentioned before, but when it's taken on 7 days and a minimum of 5 days, in the morning and in the evening, it really reflects better the real blood pressures over the course of time and on a daily basis. So it should be taken twice in the morning, twice in the evening with 1 minute between measurements. There are many pictures and infographics on how to do home blood pressure monitoring. And on this specific one, there's an aspect that wasn't included on the previous one, which is what I would like to highlight. Firstly, and this is just to demonstrate how blood pressure changes from second to second, just to emphasize the variability of blood pressure and how just by speaking, we can significantly increase blood pressure. Just speaking or thinking of something stressful changes that. And that's why it's really important to rest 5 minutes before the measurement. And that's what I really want to highlight, is not to talk as you take a measurement. People don't realize how much that changes your blood pressure, even during the 5 minutes of rest. If you can avoid your phone, avoid speaking to someone and just be almost in a meditation state, which would be ideal. This sheet was developed by international organization, Stride BP, and it's quite helpful for a person measuring blood pressures at home. But you can also use a notebook and just make sure that it's done in a consistent way. So it helps you to record details such as the day when measures were taken, the time of day, and then 2 in the morning and 2 in the evening. And so this would give you a 7-day record, which you can then give to your healthcare provider for easy checking over the course of a week. It also reminds you on how to take blood pressure accurately. I'm now getting back to the point I've mentioned earlier in terms of adherence to medication. That is really a critical aspect, and it often goes hand in hand with home blood pressure monitoring. Because when you measure it at home, it can actually act as a driver for you to continue to take your medication appropriately. It was shown that if you don't take your medication, which is quite logical, then you will have high blood pressure and it would increase your risk of death from 50 to 80%. It was also shown that in the US, for example, 51% of Americans treated for hypertension don't follow the advice of the healthcare provider when it comes to medication therapy. So many people with prescribed medications don't take it. It is a major issue in the field. As you can also see from this statistic, for every 100 prescriptions written, only 15 to 20 are refilled as prescribed. In other words, only a few people, so 50 to 70% actually go to the pharmacy and actually use the medication as prescribed. So my take-home message in 3 points. Firstly, it's really easy to take blood pressure at home. You can simply follow the steps as outlined by the Australian Heart Foundation on that beautiful leaflet. Secondly, it's important to keep daily track of your measurements. Using a sheet like the one developed by Stride BP that can easily be downloaded from their website is very useful. And lastly, extremely important to take your medication as prescribed by your doctor. Thank you very much. I'm happy to take any questions or be contacted. Thanks.
Thank you very much, Alta, for a fantastic presentation. So what we'll do, we will have all the questions at the conclusion of the four speakers during the panelist session. So feel free to type your questions in the Q&A at any point, and then those questions will be answered at the end during that panelist session. So our next speaker is Dr. Rachel Climie, who you've already met. Rachel's a clinical exercise physiologist and Heart Foundation postdoctoral research fellow specialising in vascular ageing. And as you can see, Rachel's going to talk about lifestyle changes for preventing and lowering high blood pressure. Take it away, Rach.
Okay, great. Thanks very much, Dean. Oops. Okay, so as we've heard from Alta and Marcus, high blood pressure poses a significant burden. Oops, just slides to work. So elevated blood pressure is the leading modifiable risk factor for heart disease. And as Marcus mentioned, heart disease is the leading cause of death in Australia and kills 1 Australian every 12 minutes. In terms of the economic burden, an estimated 10% of the global healthcare expenditure is directly related to high blood pressure and its consequences. So why then are we interested in lifestyle changes for the prevention and management of high blood pressure? Well, as we've heard, adherence to blood pressure lowering medication is poor. And in fact, actually only 46% of people who are prescribed blood pressure lowering medication don't actually have controlled blood pressure. And secondly, 95% of people who have high blood pressure have what we call essential hypertension, meaning that there's no specific cause for the high blood pressure, but it may be linked to a number of modifiable risk factors. And these risk factors include things such as physical inactivity, obesity, poor diet, smoking, and excessive alcohol consumption. So if we can modify these lifestyle factors, we can potentially prevent a large proportion of high blood pressure. And the good news is this can be done relatively easily and is inexpensive. So I'm now going to provide you a little bit of information about the risks associated with these lifestyle factors in terms of high blood pressure and how we can modify them in order to prevent and manage high blood pressure. In the interest of time tonight, I'm only going to focus on physical inactivity, obesity, and poor diet. So firstly, for physical inactivity is responsible for 5 to 13% of cases of high blood pressure. Indeed, each hour spent sedentary or sitting per day increases the risk of high blood pressure by 2%. This figure here shows or demonstrates the importance of maintaining physically active throughout the whole life course. So as you can see, those individuals who were active at age 23 but were not active at age 45 had the same risk of high blood pressure as those who were not active at age 23 and not active at age 45. So this really highlights that even if you were active as in your 20s as a student, it's really important to continue to be active as you age. So in terms of preventing high blood pressure, what do the guidelines recommend? Well, this recommendation comes from the Australian Institute of Health and Welfare and is for physical activity in Australian adults. And these guidelines suggest that we should be engaging in 150 to 300 minutes of moderate or 75 to 150 minutes of vigorous intensity aerobic activity per week. So aerobic activity is activity in the form of walking, cycling, swimming, tennis, and so on. Moderate intensity refers to an intensity where you're huffing and puffing, but you'd still be able to maintain a brief conversation with the person next to you. Whereas vigorous intensity exercise refers to an intensity where you wouldn't be able to talk to the person next to you. These guidelines also recommend that we engage in strength training or lifting weights, and that this should be done on 2 or more non-consecutive days per week. So if you're someone who already has high blood pressure, the Heart Foundation has provided these guidelines in terms of managing hypertension or high blood pressure in adults. And they suggest that for those people who already have high blood pressure, you can engage in the same amount of physical activity at the same intensity as someone who doesn't have high blood pressure. And I'm well aware that given the current COVID-19 pandemic, that many of our good intentions in relation to maintaining physically active have probably been hampered this year. And so at the Baker Institute, we put together a number of home exercise programs that can be downloaded from our website and that you can do in the comfort of your own home. They include some exercises where we've got some dumbbells here. However, if you don't have any weights at home, you can simply replace this with bottles of water or cans of soup to do the exercises. And there are a number of home exercise programs available, depending on what sort of, if you've got some sort of condition or so on. And these can also be found on the High Blood Pressure Research Council of Australia website as well. Okay, so in terms of overweight and obesity, we know that 10% weight gain is associated with an increase in systolic blood pressure of 7 millimeters of mercury. And this is significant given that an increase of 10 millimeters of mercury is associated with a 50% increased risk of death from heart disease and stroke. So then in terms of preventing high blood pressure, does weight loss actually affect blood pressure? Indeed it does. So a 5 kilogram reduction in weight is related to a 4 millimeters of mercury reduction in blood pressure. And again, this is significant given that 10 millimeters of mercury reduction in blood pressure is related to a 13% risk of all-cause death. And if you're someone who already has high blood pressure, the Heart Foundation guidelines suggest that you try to aim for a healthy weight and healthy BMI. Okay, and finally for poor diet, we know that processed foods are high in unhealthy fat and sodium or salt and low in potassium. In fact, 75% of the salt consumed by the Australian population comes from processed foods. And potassium is really important in the diet because it helps with the excretion of salt in the urine. So unhealthy fats such as saturated and trans fats increase the narrowing of blood vessels, elevate blood pressure and lead to heart disease. Increase more than 5 grams of salt per day is related to high blood pressure, 17% increased risk of heart disease and 23% increased risk of stroke. And this is quite alarming given that Australian men are consuming double this approximately, and Australian women are consuming approximately 7 grams per day. And then finally, for potassium, we know that a diet low in potassium is related to elevated blood pressure, heart disease, and early death. So then in terms of preventing high blood pressure, we know that a diet that is high in fruit and vegetables, reduced salt and saturated fat, leads to a reduction in systolic and diastolic blood pressure. And this is just after 8 weeks. And importantly, in those people who already have high blood pressure, an increase in potassium in the diet resulted in 81% of those involved requiring less than half as much medication, and 38% required no medication at all after 1 year follow-up. So this suggests that changes that we make in the diet do have a really significant effect on blood pressure. And importantly, approximately 2.5 million deaths could be prevented each year if global salt consumption was reduced to the recommended level. So if you're someone who already has high blood pressure, the Heart Foundation suggests that you try to minimise fat intake, keep your salt intake to less than 6 grams per day, which is approximately 1 teaspoon, and include plenty of fruit and vegetables within your diet. Now, in terms of getting enough potassium in your diet, you would need to eat 11 bananas per day. Luckily, there are other fruit and vegetables that are high in potassium as well, such as avocado and sweet potato. So you don't need to have a diet just of bananas. These guidelines also mention smoking and alcohol consumption. So just briefly, if you have high blood pressure already, they suggest that you cease smoking and that we should consume no more than 2 standard drinks on any one day, and here you can see what a standard drink looks like, and no more than 4 on any one occasion. Okay, so what? Why is it important to modify lifestyle factors for the prevention and management of high blood pressure? Well, during the course of this seminar tonight, this webinar, 7 Australians will lose their lives to heart disease. We know that high blood pressure is a leading risk factor for heart disease. And 95% of high blood pressure has no single cause but may be linked to unhealthy lifestyle. So if you're someone who has high blood pressure or is at risk of high blood pressure, let me leave you with this. Every morning when we wake, we have an opportunity to create how we're going to be. We can choose whether we're going to be someone courageous who takes on changing our lifestyle, even though it's challenging, or we can be someone who's going to give into our reasons for not changing our behaviour. Ultimately, we are all 100% responsible for the actions that we take. You can choose to ignore what I've said tonight, or you can choose to take on what I've said and alter some of these lifestyle factors if they are relevant to you, and minimise your risk of developing high blood pressure or the related consequences, including heart disease and early death. So thank you very much, and please reach out to me if you've got any questions at all. I'm more than happy to help. Thank you.
Fantastic. Thank you very much, Rachel. Wonderful presentation and very important messages there. So we'll move on to our last presenter for this session, who is Natalie Raffoul. She's the Risk Reduction Manager at the Heart Foundation. And as mentioned earlier, PressureWise is a joint initiative of the High Blood Pressure Research Council of Australia and the Heart Foundation. So we're thrilled to have Natalie here to speak tonight. Over to you, Natalie. Thank you.
Thank you, Dean, and it's a real pleasure. The Heart Foundation are really excited to be partnering with the High Blood Pressure Research Council of Australia, and certainly really savour the opportunity to talk to so many of you across the country today. Thanks for your attention, and I think I've been placed last on the queue really appropriately, because I think my next 8 minutes or so, I think I can tackle in 8 minutes, will be largely focused on giving you the broader picture of your risk of developing heart disease. Blood pressure, or high blood pressure to be exact, is a really, really important risk factor for heart disease. But there are a few more, and hopefully this will bring you to understand a little bit more about that. And Rachel's presentation before me provided a great foundation for that also. So I really don't need to go through this slide whatsoever. I think we've all got the picture. Heart disease is still Australia's single leading cause of death. And what I want to emphasise is that the Heart Foundation and many, the researchers here are really committed to the prevention of heart disease. And a large part of that is because we know that such a significant chunk of the burden of heart disease is due to premature deaths. So people are dying earlier than they should, rather than living years and years with a disability. And this makes us really want to focus all our attention on preventing it before it strikes. And it can often, unfortunately, strike without much warning. I know you've been overwhelmed with stats today, and I hope that this will be one of the last you'll hear, but I wanted to really emphasise that there are 2.5 million Australians across the country that are at high risk of having a heart attack or stroke in the next 5 years. That is, their probability of having a heart attack or stroke is greater than 15%. And the scary part is that over half of these people have never had an event before. And so it's likely that heart disease isn't even on their radar. As I mentioned, blood pressure is a really significant and important risk factor for developing a heart attack or stroke, but it's one of many. And unfortunately, it's not as easy as counting all your risk factors and adding them up and scoring yourself and seeing how you do. Often we hear from a lot of people that say, look, I've got a really healthy lifestyle. My heart disease risk must be very low. And unfortunately, again, it's not as simple as that. But what we do know is that risk factors can combine and increase your chances of developing a heart attack or stroke. And they can combine in different ways. And that can be be a mixture of things like your genetics, your lifestyle, and some of your clinical conditions, which I'm happy to run through very quickly. There's certainly some things you can't change that do increase your risk of a heart attack or stroke. Things like your age, as you get older, your risk increases, unfortunately. Your ethnicity, we know that people that are from Torres Strait or Aboriginal or Torres Strait Islander descent are more likely to develop heart disease compared to non-Indigenous Australians. And we know other individuals from a South Asian, Maori or Middle Eastern background also tend to have a higher risk of developing heart disease. Men are at higher risk of developing heart disease, but women catch up, but they just catch up in their risk after menopause. So it's a bit of a delayed risk profile that we see in comparison. And family history, that's one that we hear really often. Family history is a significant risk factor for heart disease. It's hard to quantify this one, so I can't tell you if you have a family history, you've got double the risk. But we know that if you have an immediate family member that has had a heart attack or a heart event before the age of about 55, then your risk is increased. And again, these are things you can't change, but the good news is, and as Rachel has so eloquently described, there's lots we can do to change our risk factors. And a lot of that has to do with our lifestyle, smoking, and healthy eating and physical activity has been well described by Rachel. I want to emphasize that the Heart Foundation has a lot of programs, resources and information on these things online, including lots and lots of heart healthy recipes and even healthy eating plans to help you over Christmas. And we also have a free walking group. Over 80,000 Australians across the country participate in this walking group. It's a free physical activity or exercise that you can participate in, but it's also very social, and we hear a lot of positive feedback from that. Cholesterol is another really strong risk factor for heart disease. It's one of the leading risk factors for heart attacks. And this is because LDL cholesterol or bad cholesterol can stick to the walls of your arteries, and it can cause blockages and stop oxygen-rich blood from getting to your heart. And that essentially can cause a heart attack. So focusing on understanding what your cholesterol is or knowing your numbers is the first most important step you can take around that. And I emphasize that because very similar to blood pressure, there's often very few symptoms of high cholesterol. So it's a silent killer, as we call them both. Blood pressure has been covered very well, so I won't repeat that. Another one that I really want to emphasize is diabetes. We know that people living with diabetes have a much higher risk of developing a heart attack or stroke. In fact, they can have almost double the risk compared to people that don't have diabetes. So it's really important to keep on top of your blood sugar levels if you do have diabetes and take your medications as prescribed. Sometimes it's hard to imagine what your risk of heart disease is. You know, I told you 15% probability, and that doesn't sound like very much, right? But we know that something like the Heart Age Calculator tool that the Heart Foundation launched last year can help you understand what a higher risk means to you. And it essentially communicates this in a understandable and motivational way. So it tells you your heart age compared to your actual age. It takes about 2 minutes to complete, and I really encourage you after this session to visit myheartage.org to complete the test. It takes about 3 minutes, and it's for people 35 to 75 years without heart disease or who haven't had a heart event previously. And it helps you to really recognize what your multiple risk factors, including your blood pressure and other lifestyle and clinical and age-related factors, how they interplay to increase your risk of developing heart disease. Of course, I've been talking a lot about risk, but I also want to emphasize that there's plenty that we can do and really clear first steps or tangible steps you can take after this session today. If you're 45 years and over, or if you're 30, for Aboriginal and Torres Strait Islander peoples, I really encourage you to book in, tomorrow with your GP for a regular heart health check. It's not a fancy check where you're going to jump on a treadmill. We're not going to put anything up your arteries like an angiogram or anything like that. But it is a chance for you to sit down with your GP and often your nurse to understand what your risk of developing heart disease is and take the right steps, work together with them to lower your risk. And sometimes it's got a lot to do with your lifestyle, as we've emphasised, but sometimes you need some support and help through other interventions, whether they be medications or whether they be a referral to a dietitian, for instance. It only takes about 20 minutes and it's covered by Medicare, and so it will be free if your GP is bulk billing that item. And like I said, your doctor will help you check all your clinical risk factors, your cholesterol, your blood pressure, your blood sugar levels. They'll take a full medical and family history and ask you about your lifestyle. And they will use all that information and use a validated risk score known as the Framingham Risk Equation. It's the calculator that all of our health professionals across the country use to estimate your risk of developing a heart attack or stroke in a really validated way. So it's not just us looking at you and saying, oh, you've got a few risk factors, you might be at high risk. This is a evidence-based way of us calculating that. And then most importantly, they'll work with you to set a plan for improving your risk factors. Like I said, it might include medications, it might include referral to for some more support, and it will certainly help you, particularly if you've got certain concerns about your family history, your genetics, your other conditions. So it's very personalised. I think this has been really spoken to very well across the different speakers tonight, but it might be something very nice to leave you with. These are some 10 steps that the Heart Foundation have pulled together to help you to protect your heart, whether you have high blood pressure or not, or whether you've had a heart event or not. They sound very simple, but as Marcus said, it's easier said than done. But certainly keep eating a heart-healthy diet, moving more, being smoke-free, maintaining a healthy weight, drinking less alcohol, knowing your blood pressure and cholesterol levels and how to manage them, managing your blood sugar levels if that's relevant, managing your mental health, because that's a risk factor I didn't quite get the chance to cover, but it certainly does interplay with your risk of developing heart disease, and seeing a GP for a regular checkup across the board is really recommended. I highly encourage you to visit the Heart Foundation website. We've got lots of resources, animations, recipes, walking groups, and much more tools and bits and pieces that will do a lot more justice to you than this presentation, and will give you a lot more detail. Thank you.
Great, thank you very much, Natalie, for a wonderful presentation and overview of the Heart Foundation and the heart health checks. Now, can I please ask Alta, Marcus, Rachel, can you please switch your videos back on, and Natalie as well? Sorry, you need to stay with us. Sorry. So we've got a few questions that have come up in the Q&A, and everyone, please feel free to type your questions in as and we'll get to them over the next probably 8 minutes or so. So Marcus, we'll start with the question to you, which came through during your presentation. Are salt substitutes like potassium chloride and liquid aminos advisable?
Well, I think Rachel already alluded to the fact that potassium is certainly better than sodium. And if we talk about salt, essentially we talk about sodium, and that has been shown, particularly in patients who are prone to develop hypertension, sometimes to have severe impact on the rise in blood pressure. On the contrary, if you manage to reduce your sodium or salt intake very frequently, you can see not only that the blood pressure comes down, but also, and perhaps equally important, if you are on blood pressure lowering medications, a lot of those medications actually work better in a low sodium or low salt environment. And there's additional benefit in regards to that. Whether to replace whether to replace sodium with potassium, in general, yes, that is usually a smart move. So higher potassium has been associated with better blood pressure control. The only caveat is, if your kidneys don't work all that well, that can sometimes be, you have to be a bit cautious, but in general, I think it's a good idea to replace sodium with potassium. but again, in moderation and best together with your GP to get some guidance.
Great, thank you very much, Marcus. So now, Alta, we've had a couple of questions about monitoring blood pressure at home. So I've kind of combined them a little bit. What's the optimal number of blood pressure measurements to take at home? And secondly, is it a problem if the first measurement that you take is higher than the subsequent readings?
Thanks, Dean. And also thank you for that question. I think it's so important because we all know when you work with blood pressure a lot, it's usually normal for the first one to be a lot higher than the rest. That's why in the doctor's office, it's usually taken 3 times. So, and in that case, the second and the third one are used and they are averaged. For home blood pressure monitoring, it's always advised to take it twice, but it's even better if you can take it 3 times. And then usually we suggest to use the average of the last 2. It is basically due to that anxiety that I referred to earlier. So it's normal to have, when you put it on the first time, to think of other things or to just be a bit anxious and then to relax and get used to the measurement, and then the blood pressure always goes lower. That is very normal. So never take one measurement. It may be higher than it should be.
Great, thank you, Alta. Just another second question for you on blood pressure monitors. An attendee has bought one. It was cheap in cost. Does that mean it was no good, or does that mean it is no good?
I really want to give you that question, Dean. Everybody, this is really Dean's area of expertise, but Dean, you can elaborate, but there is a good likelihood that it's not a validated device. There are ways to check it. Dean, do you want to perhaps give some further advice there?
Sure, I would just say, Alta mentioned the Stride BP organisation, which is one, if you go to that website, stridebp.org, you can look up devices that are validated for accuracy, which means they've been tested properly for accuracy.
Unfortunately, the vast majority of devices out there, especially all these wrist devices that you can buy easily, they are not validated and therefore not advised to buy them, even though they look very nice and are cheap, cheaper than the other ones that we would recommend. Please be sure of that. And as Dean said, stridebp.org, there's lists of devices that are good.
Okay, thank you, Alta. Rachel, we've got a question here for you. Is there a way to find out if your potassium levels are high enough?
Oh, that's a good question. And actually, Marcus, as a clinician, may be able to comment, but I would say a blood test would be able to tell you that.
Absolutely. So now potassium and sodium are usually very closely regulated because they're very important, for our cells to function normally. And as long as you have normal kidney function and no other major conditions, sodium and potassium are, in a very narrow range. And in fact, if it goes beyond, people often get symptoms with potassium in particular, such as arrhythmias, irregular heartbeats, etc. So 2 ways. There's a blood test, which gives you an indication where in the normal range you are. And then you could also do a urine test, and that is more a test to give you an indication about your dietary intake. And that is relevant both for sodium and for potassium. With a normal functioning kidney, if you eat a lot of salt, more salt will appear in the urine. So it's a good indicator of how much actually you consume. And I do that quite routinely in my clinical practice when I see patients with high blood pressure. And let me tell you, very routinely, we find that there's too much salt in their system, and reducing that can have a significant impact. So 2 ways to measure, and your GP can help you with that quite easily.
Great, thank you, Marcus. Next question, I think probably was best suited to Rachel and Natalie. So maybe you can both have a go at this one. Given that knowing one's numbers for blood pressure is critical to understanding cardiovascular risk, A, what percentage of people know their numbers? So we're talking about health literacy. And B, what percentage of the population over 35 years have their blood pressure measured by their GP each year?
great questions. And Nat, I don't know if you know the exact percentages. I don't happen to know the exact percentages, but I would say that based on European and US data, we know that about 50% of adults are health illiterate. So they're actually not able to understand and act upon health messages, which is quite concerning given that we're trying to prevent these diseases. If people don't actually understand the messages that we're giving them, then there's something wrong there, certainly.
Yeah, I absolutely agree, Rachel. The Heart Foundation has actually looked into a bit of this, both from a data around measurement perspective, but also how many people recognise blood pressure as a risk factor. And it's as you've sort of described. It looks like the picture across Australia is that the majority of people get their blood pressure checked at least every 2 years, and that is people above 45, and they get that recorded in their GP software. So when you go visit your GP, they check it, it's in the software, so we know it's being measured. But then when we ask people what their blood pressure is, only about half can give us a number, and then subsequently when we ask them what are the most important things you can do to reduce your risk of having a heart attack or stroke, only 2% of people nominated lowering their blood pressure. About 70 to 80% nominated eating healthy and being more active, but only 2% recognised that blood pressure was a risk factor. So you summarised it really well, and the data certainly supports that health literacy gap.
Great, thank you. We've probably got one more here. Cardiovascular. So to Natalie, sorry, cardiovascular risk. The cardiovascular risk score for patients greater than 75 years. Why doesn't it apply?
Look, the only reason why people older than 75 aren't included in the calculator is because the calculator itself is based on, as I mentioned in my presentation, the Framingham cohort equation. So that's validated data that we've taken from a big study with lots of, thousands of people in it, and we've monitored their risk factors and then measured their outcomes over time. And in that particular study, people over 75 weren't included. So that's one thing. That's why it's not in the calculator. Very practical and logical explanation for that. The second reason is that it's fairly well recognised, particularly in the guidelines, that people that are over 75 are automatically at higher risk, or automatically have a higher risk of developing heart attacks or strokes by virtue of their age. Remembering that age is a very strong predictor of risk when you look at somebody's overall risk. So those are two of the reasons. And I'd say the third, from a clinical perspective or a practical perspective, is that if you're over 45, your risks and the benefits of medications or other interventions really need to be individualized. So you need to sit down with your GP, and rather than having a bulk standard, here's your blood pressure medications, lower it, let's go. It needs to be a bit more customized to your needs at that age.
Great. Thank you, Natalie. Now, I'm aware that we do have a few more questions in the chat, but I think in the interest of time, we'll need to move on. So we will try to address those if we can as we go, or later on, because we will have a record of those. So I'm going to hand over to Rachel now, who will chair the next session. But a big thank you again to all our speakers from this first session. Extremely informative.
Okay, great. Thank you, Dean. So we're now going to move over to the quick presentations from our early career researchers. So they'll give you a 5-minute spiel on the research that they're currently doing into high blood pressure, and we'll have time for one quick question for each of the speakers. So if you do have a question, please paste it in the Q&A box at the bottom of your screen. So our first speaker is Neve Chapman from the Menzies Institute for Medical Research in Tasmania. So take it away, Neve.
Thank you, Rach. It's the first time this year I've had a bit of trouble unmuting. So as has been really nicely covered so far this evening, heart attack and stroke is responsible for more deaths worldwide than any other cause of disease. But I would just like to point out that it is in fact increasing as well. It's on the rise. It's something we really need to be thinking proactively about, how we can identify who's most at risk. And as has also been touched on today, is that there's risk factors associated with who's most likely to have a heart attack or stroke. And what I'd like to draw your attention to, and Natalie touched on this in the previous talk, is that the more risk factors you have, essentially they interact together and they put you at much greater risk. So if we look at the blue line there, people with one risk factor are at much lower risk than those with the orange line who have 2 risk factors or more. And this is really important because most Australians, in fact 90%, have at least one risk factor and about 60% have 2 or more. So it's highly relevant to many adults in Australia. And as Natalie mentioned, for this reason, we use a risk calculator based on somebody's risk profile, so all of the risk factors that they have, to work out whether or not it's likely they might have a heart attack or a stroke. Unfortunately, the evidence shows us that this is used in practice by doctors less than 30% of the time. And there are a number of challenges associated with using this approach. Essentially, GPs struggle to collect the risk factors within the time required in consultation. There's low use of the actual calculator itself because they have to go to a specific part of their software. They may not have all the risk factors they need. And essentially, this results in them focusing on single risk factors, predominantly focusing on just treating your blood pressure or just treating your cholesterol, when in fact, we know if we looked at overall at your risk factors, we would best identify who needs treatment. One opportunity to potentially address this deficit of who we're identifying at risk is when somebody goes to have their cholesterol measured at pathology services. At pathology services, we could collect more risk factor information, measure blood pressure according to high quality measurement methods like ALTA's mentioned. We could estimate absolute cardiovascular risk, and crucially, we could report this to your doctor. And this is essentially the study I'm going to speak to you about today that's done in partnership with pathology services. And to talk you through it briefly, essentially, a patient would be referred for a cholesterol test by their doctor. When they go for that blood sample to be collected to measure cholesterol at pathology services, they would complete a health questionnaire and have their blood pressure measured using a custom-made app. And that app would then send that information to the pathology lab, where it's matched with their cholesterol result, and it's used to work out the risk score according to recommended guidelines. And then that information is added to the blood test report and sent to their doctor. And here's essentially what that report would look like. We can see that the extra risk factors are there and the score and risk category as well, alongside some treatment recommendations based on the level of risk. So the first thing I'd like to talk you through is some pilot work that we did about whether or not this service works. So we tested it at a practice with our nice booth and our computer in 300 patients. And essentially we asked them, did they like it straight away afterwards? What would they improve? And we also phoned them over 6 months to identify what had happened with their follow-up care. And briefly, it worked 90% of the time, and we're working on getting it up to 100% of the time. And 17% of people who took part were at high risk for a heart attack or stroke. It took just less than 17 minutes to complete the app, including the questionnaire and blood pressure measurement. And 91% of our population found it easy to use the app, which was really promising. And then over that 6-month period where we called people, 75% had seen their GP. And of those, 74% had had cholesterol discussed with them. And the blood pressure measurement we took was discussed with nearly 70% of people, while cardiovascular disease specifically was discussed with 40%, which is really promising. Next, if we briefly look at GPs who we interviewed and discussed the blood test report and the service with them, if you'll remember, I identified there were a number of challenges that GPs face. And in these interviews, essentially, they said it's difficult to collect risk factors and often requires multiple visits, or it's done at the end of a visit for you come in with a stubbed toe and I will just measure your blood pressure while we've got time. This results in low use of risk calculators, but often it's more so used as a communication tool to help explain risk rather than to actually guide treatment. And they agreed that they focus on single risk factors. But they did identify that this service at pathology services would address this by systematically screening every single person that has their cholesterol measured. It streamlines the process, requiring fewer consultations, which makes it better for doctors and patients. It would prompt a specific follow-up about cardiovascular disease management, particularly when the cholesterol would have been normal. And it would improve communication as an objective third party saying somebody was high risk. And all of our GPs said that they would request absolute cardiovascular risk via pathology services if such a service was available. And I'd just like to briefly say, because of these great findings, we're now rolling it out across Tasmania, and we're going to recruit participants to see whether or not this really does result in better outcomes for patients. So stay tuned for more, and we'll see what happens. So there's the study information if you'd like to get in touch with either myself or with the primary chief investigator, Professor James Jarman. Thank you, Rachel.
Thank you, Niamh. Great presentation. So I just have a very quick question for you. If you see that it's successful across Tasmania, would you hopefully aim to roll it out across the rest of Australia? Is that your plan moving forward?
Yeah, definitely. So we, as with all medical research, it's subject to grant funding. We are very lucky that we have an industry partner, but we would hope to start off with probably Melbourne, South Australia, and roll it out in specific pockets first. But the technology itself is broadly implementable and scalable at very low cost across the whole country and even internationally.
Okay, great.
Thank you.
Thank you for your presentation. So we'll move to the next speaker. So our next speaker is Quinn Nudin from La Trobe University. So over to you, Quinn.
Thanks, Rachel. So as it's been previously mentioned, high blood pressure causes a lot of damage in different organs in the body, but my research focuses on the effects of high blood pressure on the brain. Because we know that high blood pressure is the leading risk factor for detrimental brain diseases such as stroke and dementia. And I'm interested in dementia because dementia is the second leading cause of death in Australia. And unfortunately, there's not many effective treatments for dementia. The current treatments for dementia only treat the symptoms, but they can't actually stop the progression of dementia or reverse the damage caused by dementia. And so this leads into my research goals. We want to understand how high blood pressure can lead to the development of dementia. And we want to use these findings to develop new treatments to reverse, or even prevent dementia. So my research focuses on inflammation of the immune system. The immune system is our body's defense force against infections and foreign pathogens. It consists of many different types of immune cells and inflammatory markers, and they all work together to attack and defend the body against infections. However, too much inflammation has harmful effects, and sometimes our immune system can attack our own bodies. So there are a lot of diseases where inflammation has harmful effects, some of which you'll be familiar with, such as asthma, stroke, dementia, and even high blood pressure. There's now a lot of evidence that during high blood pressure, there's an accumulation of immune cells in organs such as blood vessels and the kidney, which are important regulators of blood pressure. However, there hasn't been much study in the brain. And so we wanted to ask, does high blood pressure cause inflammation in the brain? And can this brain inflammation cause dementia? So I'm just going to go through some of the data we have found so far. So we have found that high blood pressure increases immune cells and inflammatory markers in the brain. If you have a look at this graph here, the blue bar represents data from the brains with normal blood pressure. And so you can see here, the average number of immune cells in the brains with normal blood pressure is around 3,000. Whereas the green bar here represents data from the brains with high blood pressure. And in these brains, there's about 6,000 immune cells here. And so this shows that high blood pressure doubles the amount of immune cells in the brain. We've also looked at inflammatory markers, and similarly, if you have a look at the data from the brains with high blood pressure, there's almost 3 times the amount of inflammatory markers compared to the brains with normal blood pressure. And so this is compelling evidence that high blood pressure does increase inflammation in the brain. We've also looked at blood flow, because blood flow is extremely important for healthy brain function, because blood flow provides the energy and nutrients that the brain requires to function properly. And so this is an image of a brain here, and the red is blood flow. And so this is what normal blood flow looks like in a brain with normal blood pressure. As you can see, during high blood pressure, there's an increase in blood flow to the brain. And so this is potentially a mechanism by which high blood pressure may increase inflammation in the brain, because the immune cells, they circulate in the blood. And so if there's more blood flow to the brain, potentially this is how more immune cells are entering the brain. We've also found that high blood pressure causes memory loss, and memory loss is a common characteristic of dementia. And so with this data in mind, what we want to do in the future is to test whether brain inflammation caused by high blood pressure causes dementia. And then we want to test whether treating the brain inflammation can reverse dementia. And so this is a team effort. And so I'd like to thank everyone that has helped me with this project, particularly the members of my lab, the Vascular Biology and Immunopharmacology group at La Trobe University. And thank you everyone for listening to my talk.
Excellent. Thank you very much, Quinn. Very interesting data that you have there. So I have one question for you. Do you know what the actual mechanism is for why high blood pressure increases inflammation in the brain?
We don't know the exact mechanism, but one piece of data I haven't shown yet is potentially, so immune cells, they require like signaling molecules to tell them where to go. So these signaling molecules will tell the immune cells like go to the brain or go to the kidney, etc. And so what we've found is that in the brains with high blood pressure, there's an increase in these signaling molecules. So potentially more of these molecules are telling, telling these immune cells come to the brain. So that's why there's more of these immune cells entering the brain. So that's one potential mechanism.
Okay, great. All right, thank you. In the interest of time, we'll move on to the next speaker. So our next speaker is Rikesh Mutharan, sorry, Rikesh, who is from Monash University. So Rikesh, over to you.
Thank you, Rachel. Thank you for the opportunity to present my research today. I'm Rikesh R. Munitharan, a second-year PhD student at the Marcus Lab School of Biological Sciences, Monash University, Melbourne. I'm very excited to talk to you today about my research on how we could harness gut microbes for high blood pressure control. Now, we have a problem in our hands. 1 in 3 Australians have high blood pressure, which accounts for more than 6 million people. You may wonder, why do we need to study high blood pressure? Because many medications are available. Unfortunately, as highlighted by previous speakers, more than half of these people have uncontrolled or unmanaged hypertension. Now, unmanaged or uncontrolled hypertension causes death, and it also causes heart attacks and strokes. Now, because of this, we need to find new treatment options. What do we know so far? So we know that a healthy diet, especially one rich in fiber, is beneficial to health. And there are many studies that show, studies in humans that show that fiber can reduce or lower blood pressure. Now, food high in fiber, for instance, include green vegetables, berries, avocado, and bananas. But how does fiber lower blood pressure? Now, that's what I'm here to tell you about. So dietary fiber that we eat cannot be digested by humans because we lack enzymes to digest them. However, dietary fiber, when they reach the large intestine, the part of our gut, they are digested by microbes that live in our gut. Now, when the microbes digest fiber into smaller molecules, these smaller molecules are able to enter into the bloodstream, and some of these molecules are detected by detector cells in our body. Now, the interactions between the small molecules and the detector cells results in the lowering of blood pressure. Unfortunately, only 20% of Australians take the recommended fiber. Even then, some of the microbes are different in people, which means that not all the molecules produced are not the same in all people. Now, is there an alternative to this? So the alternative is something that I'm interested in, which is whether we could produce a pill that can activate the detector cells and reduce the blood pressure. So now in this case, what we can do is to bypass the fiber that we need to consume, as well as bypassing the problem where the gut microbes are not similar between people. So my research is still in a very early phase where I'm really trying to understand the interactions between the detector cells as well as the small molecules and how they actually reduce blood pressure. So in conclusion, how our gut microbes can affect blood pressure and can be targeted for treatment of blood pressure is a new and exciting field. But until we are able to produce medications targeting this or producing treatments that target molecules, we should all eat enough fiber. And we are in the process of running a clinical trial here in Melbourne for people with high blood pressure who are not on treatment. So we are using diet to treat high blood pressure. So if you are in Melbourne and if you are interested, you can check this website or call this number to find out more information. Thank you. These are people who are involved in our research.
Okay, thank you very much, Rikesh, for this great presentation. We've just had one question come through. I'm not sure if this is related to your work. Do you know if there is any connection between high blood pressure and high uric acid levels?
That's actually a very good question. Uric acid is also associated with metabolic syndrome as well. But for my study or for our study, I'm not very sure about that. But I think we can look into that further. Thank you.
Great, thank you. And can I just ask you a question? So if we should be eating high amounts of fibre, what would you suggest that we should be actually eating to lower our blood pressure?
That's a very good question. So the recommended fiber is about 30 grams is what is recommended. And one banana has about 4 grams of fiber. And green vegetables and so on. Avocado has very high fiber as well. So, yeah.
Okay, great. Thank you, Rikesh. Okay, so we'll move on to the next speaker, who is Dr. Audrey Edgy from Victor Chang Cardiac Research Institute. So over to you, Audrey.
Thank you, Rachel. So I'll just share my screen. Okay. So I'm Dr. Audrey Aji, and I'm a researcher based in St. Vincent's Hospital, Sydney. High blood pressure may be the inevitable consequence of getting older, but there are steps to delay the harmful process. Based on data from the 2018 Australian Bureau of Statistics National Heart Survey, about 1 in 3 Australian adults have high blood pressure. Of this, some do not even know that they have high blood pressure. This graph is taken from the Framingham Heart Study in America, which Natalie mentioned before, a long-term observational prospective population-based study to investigate risk factors of heart disease, which includes age and blood pressure. As we can see, blood pressure will continue to rise from age 30 years onwards. By the time we reach age of around 50, the systolic or top number keeps getting higher, while the diastolic or the bottom number will decrease. The difference between the top and bottom number we calculate as a pulse pressure becomes greater as we age, and this is unhealthy. This pattern remains true worldwide regardless of ethnicity or lifestyle. So what caused the high blood pressure in older individuals? In this slide, I compared a typical aorta of a young person on the left side with a typical aorta of an older person on the right. With every beat, the blood is squeezed out from the heart, and the energy created by this action creates a pulse that we can feel in our wrist or neck. When we are young, healthy adults, the aorta, that is the main tube connecting the heart to the rest of the body, has an elastic or stretchy wall. Therefore, it can soften the pulsating beat, and the blood pressure taken at the arm is normal. However, as we humans getting older, the aorta dilates and becomes hardened and kinked, and lose its ability to soften the pulsating beat as its wall has been stretched millions of times during life. The higher pulsating energy is transmitted down the aorta, and blood pressure taken in the arm is higher. With the current non-invasive diagnostic tools, and this has always been my research focus, we can estimate the workload of the heart by measuring blood pressure and flow simultaneously in the aorta, blood flow with heart imaging, and pressure with mathematical derivation of pulse recorded at the wrist. The workload estimation is done using the analogy of electricity known as Ohm's law in physics. Using this analogy, pressure is related to flow, and this will give us an indication of how elastic or stiff is the aorta. The total work required is equivalent to the resistance the heart has to overcome to push the blood out. So why it is important to know how stiff is your aorta? Let me go back to the previous slide. Apart from the heart having to operate at a higher load, as the aorta hardens, the pulsating energy from the heart travels faster to the end of the tube, bounce back at the time when the heart muscle is still contracting. This will cause the heart to work even harder and has less time to recover. The harder the heart has to work, the sooner it will deteriorate and weaken and eventually fail. Consequently, it is as important to measure the performance of the heart so we can detect any impairment earlier and take steps to delay the progress. A current common approach is to control your blood pressure so we can lessen the stretching of aortic wall and allow the heart to work at an optimal level. Finally, why is it important to know your blood pressure? High blood pressure can cause damage to the small, delicate blood vessels in your brain, causing rupture and bleeding, or affecting your brain function in the long term, causing dementia, as Quinn has mentioned before. High blood pressure can make your heart work harder at all the time, causing it to weaken sooner, enlarge, and eventually fails. It can also reduce the blood flow required to perfuse the heart, causing damage to the heart muscles. High blood pressure can also damage small delicate blood vessels in your kidney and affects your kidney function long term. There are other harmful consequences of high blood pressure that I won't mention here due to the time. So, I and my research group are currently working on application of these non-invasive approaches in various cardiovascular disease. And we'd like to investigate the exact contribution of the level of arterial stiffness to increasing level of high blood pressure. So at the end, get your blood pressure measured regularly so we can delay the consequences and live a healthy life towards our older age. Thank you.
Great, thank you very much, Audrey. So a quick question, can we actually measure the stiffness of our arteries? Can the GP measure that for us, or how is it done currently?
Now, currently, it's done by cardiologists or specialists. It's not something that GP can do at the moment. So the best would be talk to your GP and get them to refer you to an appropriate cardiologist. And the cardiologist can arrange this non-invasive test that we can find out more about the level of stiffness of your arteries.
Excellent. All right, thank you very much, Audrey. All right, so we'll move on to the next speaker, who is Melanie Clark from Murdoch Children's Research Institute. So over to you, Mel.
Thank you so much for letting me talk tonight. My name's Melanie Clark from the Murdoch Children's Research Institute, and today I'll just be talking about high blood pressure in children. Why should we measure high blood pressure in children? High blood pressure can lead to organ damage, and not just the heart or the arteries. The arteries actually lead blood to other organs in the body. This includes your brain, kidney, and eyes. So high blood pressure in children can lead to damage of these organs. And also, as we heard from tonight, it can lead to increased risk of disease in adulthood. High blood pressure can also be a sign of something else. It can be linked with other conditions as well. This includes heart defects, kidney disease, or genetic and hormonal disorders. So essentially, high blood pressure isn't something that just affects adults, but it can also affect kids as well, and not often as we think. So how do we determine the best way to measure blood pressure in children? This is what we do at our research group. We validate devices because a lot of times devices aren't actually validated in children. So we have to see what works and what doesn't. We also design new devices. A lot of times kids don't actually like having blood pressure cuffs around their arms, especially while they're trying to sleep or while they're at school. And what I do specifically is I'm an exercise scientist, and I look at exercise and blood pressure values. I create reference values when kids are on treadmills and they have to undergo exercise stress tests. Because in adults, we know how much blood pressure is supposed to increase during exercise, but we don't actually know how much it's supposed to increase in kids. And that's what I do. The other thing I do is I reinforce guidelines. Blood pressure is supposed to be measured in both arms, and the arm with the higher pressure is the one that we're supposed to use for future measures. Although if you think about it, how often do kids actually have their blood pressure measured in both arms, when resting or during exercise? And this can lead to blood pressure misclassification if you only measure blood pressure in one arm and you measure it on the lower arm. So what I do is I see how much of a blood pressure difference actually has an effect on blood pressure misclassification, if it's associated with any other forms of disease, and what actually causes it in kids. And because I'm an exercise scientist, I'm also interested in how to reduce the effects of high blood pressure in children. And so for kids, it often comes down to things that are similar to adults. This includes nutrition, such as lowering salt, increasing potassium, reducing sugar. And the other thing with kids is we really want to minimize the time spent sitting. Kids spend all day in school, and then often they go home, they play video games, watch TV, or spend time on their phone. And we really want to swap that with exercise, and we want to get kids moving. So how do we get kids moving? Well, the most simple method is through playing with others. And actually, if we think about it, kids need 60 minutes of playing with others and getting out and moving a day, and it should be moderate to vigorous physical activity. So a good way to play with other kids is getting involved in team sports, something like footy, soccer, basketball. They're moving and they don't really know it. And it's also great for a social aspect as well as mental health and just overall general well-being. The other thing we want to do is use exercise as a reward. Exercise with kids should never be seen as a punishment because it'll deter them in the future as well. So if your kid's doing homework, then after homework, you say, how about you go play outside? And they'll see it necessarily not as punishment, but as a reward for finishing their homework. The other thing is kids are very much the monkey see, monkey do. And so they often just want to follow the leader. And so if they see you going out exercising, chances are they're going to want to go out and exercise too. And make it something fun like going for a bike ride or jump rope, and your kid will want to get involved. If you have any questions about pediatric blood pressure, feel free to email me or hit me on Twitter. I can answer any of your questions. Thanks so much.
Excellent. Thanks very much, Mel. So I've got a couple of questions for you. Firstly, do we know what proportion of Australian children actually have high blood pressure? And secondly, if children have high blood pressure, are they likely to have high blood pressure as an adult as well?
So I'm not quite sure off the top of my head what proportion of children do have high blood pressure, often because it's undermeasured, but if you're in a class of 20, it's often around 3 to 4 kids will have high blood pressure, is from my understanding. And what was that second question? Sorry.
So that's okay. The second question was, if children have high blood pressure, are they likely to have high blood pressure then as an adult as well?
Yeah, so high blood pressure in childhood often tracks into adulthood, not necessarily every time, but we are seeing that path. So it's really good to actually try to get control and manage your blood pressure in children rather than starting in adulthood.
Okay. All right, great. Thanks, Mel. So we'll move on to the final speaker, who is Jun Yang from Monash University. So over to you, Jun.
Good evening, everyone. Oh, hold on, let me just share my slide. Usually works without problems. Okay, everyone see okay? So my name is Dr. Jun Yang. I'm an endocrinologist researcher at Hudson Institute of Medical Research, Monash Medical Centre and Monash University. Now, as an endocrinologist, I look after patients who have hormone problems. So you might be wondering, what do hormones have to do with blood pressure? Hopefully it will become clear to you by the end of this talk. You know, as a doctor, I've always found high blood pressure or hypertension to be a hard sell. You can't see it apart from the few numbers on your blood pressure monitor, and you usually can't feel it. But as all the other panelists have already explained, it's a silent menace that can strike with devastating consequences. Life-threatening heart disease, debilitating stroke. And what's more, we don't even know why it happens a lot of the time. And so to control this mysterious beast, we often have to commit to a lifetime of taking pills. But what if I told you that for a staggering 15% of people with high blood pressure, that's hundreds of thousands of Australians, unbeknown to them and their doctors, their bodies are making too much of a hormone that is the cause of their high blood pressure. And there is targeted treatment for this disease. You'd say it was a game changer, and you'd be right. For years, I've been interested in this disease called primary aldosteronism, or Con syndrome. Primary aldosteronism is a silent killer, but it's a killer with a distinctive marker, and it's easy to find if you know where to look. All that it takes to find the disease is a quick blood test to measure the hormones aldosterone and renin. Now, aldosterone is a hormone that's made by the adrenal glands sitting on top of the kidney or the beanie on the bean. The kidney, which sits right under the adrenal gland, is also important in controlling blood pressure. Normally, in response to a drop in your blood pressure, your kidneys will make more renin, which then tells your adrenal glands to make more aldosterone. And that, in turn, retains salt and fluid in the body and restores normal blood pressure. However, in primary aldosteronism, the adrenal glands are overactive and aldosterone production becomes uncontrolled, even though renin production has already been shut down. And that leads to high blood pressure. So if you have the disease, your blood aldosterone level will be much higher than the renin level. And what's great about primary aldosteronism is that there is targeted treatment available. If it's just one adrenal gland that's affected, then surgery can lead to a complete cure of the disease. Or if both adrenal glands are overactive, then you can take a specific medication that blocks aldosterone function to control your blood pressure. Now, while the blood test is simple to do, it is rarely ordered by doctors at the moment. I surveyed a group of GPs in Victoria and found that less than 1 in 1,000 of their patients with high blood pressure had the diagnosis of primary aldosteronism. This is much lower than expected based on overseas research, which suggests 1 in 10 patients should be affected. So then, to work out exactly how many patients in the GP clinics have this condition, I invited GPs from 20 clinics to order this blood test for aldosterone renin in all of their newly diagnosed hypertensive patients. And to everyone's surprise, out of 250 patients who were screened, 15%, or 1 in 7, were diagnosed with primary aldosteronism. Now, these patients would not have found out about the root cause of their high blood pressure for many years to come if it wasn't for the simple blood test. So the real game changer now is how can we make every doctor think about primary aldosteronism when they order blood tests for a patient who present with high blood pressure? And for patients to ask about the test if it has never been checked before. So if you have high blood pressure, have you had a blood test for primary aldosteronism? Thank you for listening and welcome any questions.
Thank you very much, June. Very interesting presentation. So just one quick question. Is there any signs or symptoms of primary aldosterone?
That's a problem. It really is quite silent. Apart from high blood pressure, often there are no symptoms, no signs, which is why it doesn't get looked for. In the more severe cases, you might have low potassium, which then causes muscle cramps and a whole lot of other symptoms, but that's really in the minority of patients.
Okay, great. And we've got one more question that's come through here. Would hypertension resulting from primary aldosterone be considered secondary hypertension?
Yes, so it's called secondary hypertension, but I guess secondary is just a name that we give to say that the hypertension is caused by something. So in some way, hopefully, 20 years from now, we will discover that all hypertension is secondary to something.
Okay. And so do they still have essential hypertension or it's primarily secondary hypertension?
You can have a combination, but in the vast majority of patients that we have diagnosed with primary aldosteronism, we find that either their hypertension is cured after removal of the adrenal gland or the adrenal tumour that's making the aldosterone, or it's very well controlled on the medication that specifically blocks aldosterone function.
Okay, great. Thank you very much, June. All right.
Welcome.
So we've hit 8:30. So I would like to bring this webinar to a close. Thank you all for attending and I hope that you've got something out of it. If you do have any questions or concerns, please feel free to reach out to us at the High Blood Pressure Research Council of Australia and we'll endeavour to answer your questions. So thank you everyone and have a great evening. Bye.